So this webinar is going to talk all about axial spondyloarthritis criteria. So we're going to look at the different criteria for axial spondyloarthritis, explain what the most common ones are, how we might use those in clinic as musculoskeletal practitioners. We'll try and give you some of my hints and tips as well. As we go through, I've been setting my camera up so I'm on a green screen, and I've got a few little I can do little pointing, look, so I'm going to point at a couple of things. Unfortunately, though, what I have noticed is the camera ends, so I can't point more than halfway across the screen or my arm starts to disappear. But never mind. So if you're watching with me live, then use the Q&A function to ask any questions. I will get to those at the end of the talk. If you are watching a recording on YouTube, then put them in the comments below the video and I will get to them as I can. So we're going to do a little bit of an introduction, just to make sure we all know what axial spondyloarthritis is and exactly what we're talking about when we're talking about these criteria. We will then start with the ASAS criteria, move on to SCREEND'EM, followed by the SPADE Tool at the end. So these are the most common ones I get questions about. There are lots of various different criteria, but these are probably the three most common and three most that I see used and also have questions about. So we're going to cover those three and how we might use those in clinic. So spondyloarthritis is an umbrella term and it covers two basic types really, axial and peripheral, and the difference between those is in the axial conditions. Those have predominantly axial symptoms comparative to peripheral spondyloarthritis, which has predominantly peripheral symptoms. So some axial spondyloarthritis patients will have peripheral symptoms, some peripheral patients will have axial symptoms. So there is quite a blur and overlap. But under the axial, which is what we are mostly talking about this evening, we will see conditions like ankylosing spondylitis, radiographical axial spondyloarthritis, non-radiographical axial spondyloarthritis, and then those related to other comorbidities. So enteropathic axial spondyloarthritis, usually related to Crohn's disease or ulcerative colitis, and enteropathic, I just said that one, and psoriatic, which is obviously related to psoriasis. So those axial ones in white there, they're the ones we are mostly referring to with these criteria. Axial spondyloarthritis is characterized by inflammatory back pain. Most of the patients will have inflammatory back pain, not quite all of them, but most of them will, in varying severity. So one of the key features of that is spinal stiffness. There's patient-reported spinal stiffness. They will also typically have a nocturnal pattern, so they tend to wake in the second half of the night with their symptoms, and typically they are worse in the morning, both with pain and the spinal stiffness as well. They also tend to be better with activity and not improved by rest. These do affect younger people as well. So the onset is typically before the age of 45. So we'll see about 90% of these patients onset their symptoms before the age of 40, 95 before the age of 45, and then just the 5% after the age of 45. So it is a younger person's disease, and they do seem to improve significantly with anti-inflammatories. So this kind of characterizes what we would term inflammatory back pain, and you will see that come up a little bit in these criteria as well. So hopefully that's given you a little bit of a grounding on axial spondyloarthritis. Got tons more information on that across my website and the YouTube channel. If you want more information on AXPAR and inflammatory back pain, we do go into that in a lot more detail. So, as we mentioned, these typically are younger patients. So the peak onset is 16 to 30, and as I mentioned, 90% before the age of 40. Arguably, depends where you look, slight male predominance for the axial presentation, predominantly axial presentation, comparative to female, but really in clinic you're going to see that pretty much equal male and female presentations being affected. And what is the trigger? Well, it's pretty much anything can trigger off axial spondyloarthritis. Infection, stress, increasing load, change in occupation, all these things can trigger axial spondyloarthritis. Anything that stresses your inflammatory system will kick it off. So let's get on to these criteria. So this is the ASAS criteria, and this is related, the American Society of Ankylosing ankylosing spondylitis. So the what this looks at is basically there are two arms to this ASAS criteria, and this is where you are stratifying into different types of axial spondyloarthritis diagnosis. Okay, so you're taking the symptoms that are presented, and then you use either the imaging arm or you use the clinical arm. So what this basically built upon was that they showed if you don't have imaging findings, you can still be diagnosed with axial spondyloarthritis, whereas prior to this criteria, that was much more difficult and it wasn't really included in anything. So what this uses is you've got the imaging arm where you're seeing sacroiliitis either on X-ray or MRI, typically on MRI, and then to then be consistent with a diagnosis of axial spondyloarthritis, you then need one other spondyloarthritis feature, and you can see the spondyloarthritis features there. Inflammatory back pain, we talked about what that is. Peripheral arthritis, enthesitis, so that's inflammation affecting the peripheral tendons. Dactylitis being sausage digit. Uveitis being an inflammatory condition of the eye. Psoriasis. Crohn's and colitis being inflammatory bowel diseases. Good response to non-steroidal anti-inflammatories. A family history of spondyloarthritis. HLA-B27 positivity, or an elevated CRP. So you can see that's quite obvious there. Once you've got that imaging arm of this with the sacroiliitis, you just need one of those features. And then what they did is they added the clinical arm, so you don't need the imaging feature. But this time what you will need is blood results. So you will need HLA-B27 positivity, and then you also need two other spondyloarthritis features, of which we just listed off. So this is a way of diagnosis, and as you can see, the sensitivity and specificity here is approximately 80%. So it's reasonably good, but it's not amazing. It's not absolutely brilliant, and you can really see, you know, sacroiliitis plus one other spondyloarthritis feature. There are lots of things that cause sacroiliitis, especially in females. So you can get some negative results or false positives, I should say, on both sides. I tried to address that with the clinical arm with the two spondyloarthritis features. But it is reasonably good. Now, the main problem with this criteria is those of us working outside of rheumatology. So this is designed for use in rheumatology, really, or at least in secondary care. Now, one of the issues here is we either need imaging results, or we need blood results, or we need both, okay? And we aren't always going to have access to those. We might not be able to access them specifically, or they may not have been done, and that might not be part of our job role or not accessible by us in the pathway. So there are some restrictions here to the ASAS criteria, because as we've talked about, in the imaging arm you have to have the imaging, and obviously in the clinical arm you have to have that HLA-B27 positive blood results. You need one or the other, or both at least. So that does lead us to a little bit of it's a bit of a restriction for the use of this, really. If anybody is watching and they've been on any of my courses, I advocate outside of rheumatology you're going to do the minimum investigations possible, and the reason for that is this is specifically talking about axial spondyloarthritis. Okay, there are other inflammatory diseases that won't fit this criteria, okay, but will give similar symptoms. So the problem that we've got is we've got to be really certain that we've got the correct differential diagnosis before we go applying something like this. And in my opinion, outside of the rheumatology department, that is not necessarily our job to do. So, as we'll go on to talk about in a minute, if we're suspicious of spondyloarthritis, or axial or peripheral, we're going to be referring to rheumatology, let them sort it out, let them do the diagnostics. In which case, most of the time, we're probably not going to be imaging. We're probably not going to be doing blood results unless the pathway deems it necessary to access that part of the pathway, access the rheumatology part of the pathway. So unless they've had these done already, this does have a limited application, unfortunately. is useful if you have those, not so useful if you don't. Obviously, you can get them. Would I advocate for it? Probably not. I would rather people got referred to rheumatology. So that is the ASAS criteria. You will see that. You will see that quoted, and a lot of people will go, what do they, if you ask questions about, oh, my patient has these symptoms, etc., people go, oh, have you put it into the ASAS criteria? And you say, yes, no, I haven't got imaging, a bit more difficult, so on and so forth. So it has its limited use, in my opinion, outside of rheumatology. So then we go on to the SCREEND'EM. Now, this isn't a criteria. This isn't diagnostic. This was created by Paul Kerwan. And this is a way of trying to remember the signs and symptoms of spondyloarthritis. So I put this one in here for two reasons. One, I got directly asked about it. How many of the criteria here would I deem appropriate to become spondyloarthritis? But also because it forms part of my reasoning pathway when I'm seeing patients. So what this is, like I say, this is a memory tool to help with the signs and symptoms of spondyloarthritis. What I particularly like about it is it also gives you the percentages of chance with the relation of the different symptoms. So I'm not going to go into this in tons of detail, just because I don't want this webinar to run into the length of my entire half-day course. But if we take skin, for example, with psoriasis, there's quite a big range. So 6 to 42% of patients with psoriasis will develop a psoriatic arthritis, and that depends on what kind of psoriasis the patient has and the severity of their psoriasis, and what kind of spondyloarthritis they have as well. So what I really like about this is it does this for all the different signs and symptoms here. So we've got colitis and Crohn's. There's the inflammatory bowel disease. And if we talk about that a little bit, about 1 in 4 patients with colitis or Crohn's will get a spondyloarthritis of some kind within 6 years of their diagnosis. We've got the relatives, so that's the family history, and you'll notice a lot of this ASAS criteria we've just talked about being reflected here as well. The eyes with the uveitis, the early morning stiffness, the nails is a different addition. That's part of the psoriasis. Dactylitis, the peripheral enthesitis, and the movement and medication effect is the better with activity and not improved by rest. So in here, what you've got is you've got some of those parts of the ASAS criteria versus some other components added, like the nails, for example, and that really tries to hone in on the specifics of the psoriasis. So rather than just saying, this patient has some mild scalp psoriasis comparative, that probably going to look quite a low chance of developing psoriatic arthritis. In relation to someone with nail psoriasis, they've got a much higher chance of developing psoriatic arthritis. So there's a little bit of stratification of risk there, and I quite like that because it fits nicely into my MSK reasoning process. So I do use this. It's a free PDF. You can download it. Just type SCREEND'EM into Google, up it will come. You can download it and keep that on your desk. It's a nice reminder of those questions that you need to ask, plus gives you a little bit of an elevation on how likely is this individual to have developed a spondyloarthritis. The other thing that I quite like about it is it isn't so limited to axial patients. So this is spondyloarthritis, axial and peripheral. So in the ASAS criteria, that's axial only. In this criteria, we're looking at axial and peripheral. So you could be a little bit broader with your reasoning process. And that's what we're likely to be doing outside of the rheumatology department. So really nice tool here, helps to guide your clinical reasoning process when you're considering these types of diagnoses. So then we move on to probably what my favorite tool is. And again, is this a criteria truly? Maybe it works in a similar way. It's not named that. They've named this a diagnosis evaluation tool. Is that a criteria? I don't know. Depends how you define these different words, I suppose. But this is probably the one which I direct people to mostly. Okay, so this is the one that I'll signpost people to, and what you'll see here is this is a lovely combination of the ASAS criteria, the SCREEND'EM tool, and it will give you a risk likelihood at the end. Okay, so I could do my little pointing here, look, or try and keep my arm away from the bit. So what you've got, inflammatory back pain at the top, that's what we talked about. So that's your stiffness, nocturnal pattern, better with anti-inflammatories, better with activity, not improved by rest, etc. And what you do is you tick the little, it's difficult because this is mirrored. That's harder than I was expecting. So you tick the little boxes. You just type SPADE Tool into Google and up it comes. You tick the little boxes that your patient has. So have they got inflammatory back pain, heel pain, that's your peripheral enthesitis, peripheral arthritis, dactylitis, that's your sausage digit, iritis, uveitis, psoriasis, those are your inflammatory comorbidities, good response to non-steroidals, positive family history, HLA-B27, acute phase reactant in blood tests, and sacroiliitis. So what I really like about this, so in the ASAS criteria, remember, you needed the imaging or the bloods in order to use the different symptoms to stratify the risk level, right? In this, you don't need it, but they're there if you have it, okay? So someone might have done a HLA-B27, they might have done CRP-ESR already, you might have access to that, might have done an MRI, in which case, brilliant, you can plug that into the tool, but you don't need that for the completion of the tool. So that's why I really like this outside of the rheumatology department. So you tick the boxes that your patient has, and then down at the bottom here, you click this Show Results button, and then what you get is this little graph. And the little red dot over on the side, that will move up the line that you can see, and the higher up the line, the more likely the patient has axial spondyloarthritis. So theoretically, the more the boxes you tick, the more likely it goes up. But what's great about this tool is they've stratified each box that's ticked to give it its own weighting. So on the bottom of the screen here, you'll see the research button, and you can click it and see how they developed it, and they added risk scores to each of those signs, symptoms, and so they have different weighting attached to them. So you can tick different ones, and it's not like, 2 gets you certain height up the chart. It matters which 2 or which 3. But as you go up, the more likely it is that your patient has axial spondyloarthritis. So this is perfect to use outside of the rheumatology department. Even better than that is it's validated, as we've just talked about. So on the research component there, it's a validated tool, and it gives you the advice. I'm just going to point to the advice here. Assessment by a rheumatologist is recommended, okay? So look how far my little red dot has gone up. I've intentionally put it up quite low, so we're on to additional tests necessary. Outside of the rheumatology department, I don't want people doing these tests unless it is your job role to do so, okay? If it is your job role to assess and refer into rheumatology, you do not need to do the blood results or the MRI if you are getting sufficient suspicion to refer in. Let rheumatology do it, okay? I feel like for me that is good practice. It means you don't need to be so concerned about how specific the tests and the imaging needs to be, and you're also not going to cause any delays, okay? There are delays all over the place, especially if you work in public health, potentially delays on MRIs, delays on bloods. We just don't need to do that. Get them off to rheumatology. Anything else on top of that is a big bonus. You're also unlikely to be ruling out the spondyloarthritis based on a negative bloods or a negative imaging, because as we know, some of those patients will have negative imaging. We saw that in the ASAS criteria, and some will have a negative HLA-B27 as well, negative inflammatory markers. So we do not rule out based on negative tests. So in all honesty, off they go to rheumatology, let them pick up the pieces, let them deal with the differential diagnosis, because again, there are a few masqueraders as well, which they will let them deal with. So that is probably my favorite tool. Now, what I tend to do, so my clinical practice, what I tend to do is, obviously you're assessing the patient. I've got a bit of an easy time of it because most of my work is second opinion based. So people have already had a suspicion something rheumatological is going on. But essentially what's going to happen, patient comes to you with back pain. You're asking them questions about, what's their 24-hour pattern, and you hear that they're waking in the night. second half of the night. They're particularly worse first thing in the morning, takes them ages to get going, and they're reporting spinal stiffness. They've got a history of Crohn's disease. So what you're doing there is you're using SCREEND'EM, okay, essentially. So you're running through that, and that's flagging your suspicion. Then what you're going to do is you're going to load up the SPADE tool. You're going to run through, make sure you've asked every single question, got the answers that you need, as many of those as you possibly can, ticking the box. That's going to stratify your risk here, and then you can do the referral into rheumatology or whoever it is that needs to make that referral for you if you can't make it yourself. I have sent screenshots of the SPADE tool and the results to GPs, orthopedic surgeons, whoever it is that's making the referral. I have sent screenshots and I go, I've put the patient's symptoms into the SPADE tool. This is a validated tool. Here is a screenshot of the result. It suggests assessment by a rheumatologist is recommended. So it's not just your clinical opinion, it's backed up by the weight of this validated tool as well. So if I'm completely honest, do I use the ASAS criteria? I don't. I'm not making a diagnosis of spondyloarthritis, axial spondyloarthritis. The rheumatologist is going to do it, so I'm not going to do it. So in my opinion, the ASAS criteria, it has its use, but it is minimal. We are doing the suspecting and the onward referring, therefore the SCREEND'EM as a sort of starting point and a memory jogger. So that's where I start with the SPADE tool as the sort of weight, if that makes sense, to the referral. So that's what I then use for my criteria for onwards referral. So hopefully that's made some real sense to people, cleared up any questions that people have had. I've had a few of them come in of recent, which is why I wanted to do this webinar, try and clear that up a little bit. Just to finally finish off, a little bit about me. If you don't know, I am a rheumatology specialist physio, basically because I don't really know a lot about tons of other stuff. I'm operations director for Physio Matters and Therapy Live. So if we've not seen the CPD content over there, then do check that out. Most of what I do these days is CPD and content creation. So I do webinars like this. I have courses, videos, the YouTube channel. You can check out loads of information from me on both of those. My website is rheumatology.physio. It's nice and easy. And if you do the same thing, either type rheumatology.physio into all of the social media or the Rheumatology Physio, then I do tend to come up the top of those search engines. Follow me on there, get lots of other information. And like I say, access to courses, so on and so forth, where we go into lots and lots of detail about lots of different conditions, clinical reasoning, how we might recognize, treat these conditions. And then occasionally when I take some time off, I try and play golf as well. Usually I've got a picture of me playing golf, which sort of runs here, but unfortunately it doesn't really work with the green screen and I'm overlaying it, so I've taken it out for the purposes of this. But please do check me out on social media if you haven't done that previously. So I'm going to stop my slides there. I'm going to ask if there are any questions that have come through on the live stream this evening. I've still got people here watching and listening, which is always good news. So if you haven't popped any question and you have one, I'm going to leave a couple of minutes now just for people to do their typing, should they have any questions at all. If we don't, then that's wonderful. You can always submit the questions at a later date via the YouTube channel or find me on social media. First question is Joanne's asked about, are there any known links to spondyloarthritis and hormone changes and perimenopause? So my understanding, Joanne, is actually there's a lot of hormone related changes linked to a lot of the other rheumatology diseases, rheumatoid arthritis specifically. But typically these spondyloarthritis patients are coming on a lot younger. So prior to the hormonal changes. So as I mentioned early on, peak age of onset is 16 to 30, and then the later ones are coming on only 10% are coming on after the age of 40. So there is a restricted number. So in in axial spondyloarthritis, I think it's actually less likely than in the other diseases. Helen, would I count IBS as a positive criteria? This is a great question, and it's one that I do field quite regularly on the courses. So just to clarify, it is the inflammatory bowel conditions that are specific. Okay, so the ulcerative colitis and the Crohn's disease. Now, those are obviously diagnosed. If someone has IBS and they've been investigated, they might have been to gastroenterology, then I don't count IBS as a positive criteria. So irritable bowel syndrome, I don't count that if it's been ruled out as an inflammatory condition. If it's not been investigated, then it's something that I wouldn't it's something I would consider that maybe they have an undiagnosed Crohn's disease or colitis, something like that. Recently did a podcast with gastroenterologists where we talked with my colleagues Rob and Tim about how you might notice Crohn's disease symptoms, colitis disease symptoms, and those are specific. So how might we go about diagnosing those? So IBS, technically, to shorten that answer, IBS, no. Ulcerative colitis and Crohn's, yes. Christians asked, how big a genetic component? Okay, so if you have HLA-B27 positive, okay, then you have about 8 to 12% of the population are HLA-B27 positive, and about 1% of the population are going to get a spondyloarthritis, of which about 90% are going to be HLA-B27 positive. So it's quite a big genetic component that's going on there. If there's a family history of these HLA-B27 positive diseases, so the psoriasis, the ulcerative colitis, the Crohn's, the uveitis, you have about 16% chance. So it's elevated with a family history, but not as much as with the personal history. Annika's asked, in psoriatic arthritis, would you expect joint pain flares at times of psoriasis flares, or would symptoms be more consistent / constant? So it varies between the individuals, Annika. So some people do find that when their skin flares up, their joints flare up. Some people will find that they're separated and they don't aggravate each other. Some people will find their skin's fairly stable, but their joints go, wrong hand, up and down. Some people find their joints are stable, their skin goes up and down. So it is variable between between the different types. So I wouldn't say you narrowing it down for that specific expectation, if that makes sense. Coral Coral's asked, what about celiac disease? So celiac disease, in my understanding, is there is a little bit of a link with celiac disease, but it's not particularly strong. So there are a little bit more inflammatory arthritis patients with celiac disease than sort of people without, but it's nothing like the ulcerative colitis, where it's 1 in 4 of people with ulcerative colitis are going to get it. So that's huge numbers comparative. So celiac just a little bit. So I don't tend to include it in my clinical reasoning process. Right, we've got Joanne's asked, I assume that means over 40 patients with inflammatory back pain likely to be more related to RA, SPA, low chance. Any other rheum differential diagnosis? So, Joanne, the rheumatoid arthritis doesn't tend to affect the spine. It will affect C1-2 because it's a synovial joint. I've lost the question now. Where's it gone? So rheumatoid arthritis is a synovial disease, so it tends to affect the peripheral joints as opposed to the spondyloarthritis, which are enthesitic, so it can affect the spine, sacroiliac joints. So patients over the age of 40 with inflammatory back pain, like I say, we're still going to see 10% of our spondyloarthritis patients start over the age of 40. So spondyloarthritis is still in there. You've also got things like reactive arthritis. There are other diseases as well. Some of the sinister diseases and conditions can cause inflammatory type back pain as well. And then you've go on to see things hormone related, perimenopause, menopause. Some spinal fractures can look quite inflammatory. Discitis and infections can look quite inflammatory in nature as well. So it's not that really you're considering it between RA and spondyloarthritis. What I would say is the older the patient is getting, the more likely you are to bring in a a sinister pathology into the clinical reasoning process. So think about those patients with past medical histories of cancer. They tend to be old. The older you get, the more likely that is to come in. So you might be seeing metastases rather than spondyloarthritis. So in those older patients, I have a lower threshold sort of for considering those sinister pathologies. Okay, lovely. Great questions, everybody. Thank you for that. Just checking to see if we've got any further questions. Give about 30 seconds if someone could type quickly to get one last question in before we finish for this webinar. Otherwise, I am delighted to say thank you, everybody who has tuned in. Had about 230 something sign-ups for this one. So really nice number of people signing in and jumping on. Thank you to those of you who have asked questions. Like I say, if you think of something afterwards, then please do find me on social media or on the YouTube channel, so you can watch this back. I should have this loaded tomorrow up for people to watch. If you missed any of it and you want to replay it, that's absolutely fine. Just search the Rheumatology Physio on YouTube as well. If you are watching on YouTube, do the usual, click like, click subscribe, and you'll get more of the videos. And yeah, thank you everybody for joining me. See you out in the next ones. Try to do these once a month. Don't know what the next topic's going to be. So again, if anybody wants to send me some topics to do, then away we go, and I'll sit in front of my green screen. So thank you everybody. Have a good rest of the evening. I'm going to finish up the webinar here. And yeah, I will see you all soon.